So we start off on a rather somber note. This 34th conceptual basis of urology course. Urologist, a stone man known to all of us, breathed his last Tuesday. He was struggling with pancreatic cancer for the past 2 years. He was a friend of urology all over the world, and one of his unique ability was to bring people from all spheres of life together. So Noor Buchholz, somebody who we all know, is no more with us, but I'm sure his work, whatever he has done for the cause of particularly stone disease, will be remembered forever. A little Persian stanza that "E ham nafasa mehfile ma raftid walinaz dilema," which essentially means that, oh, my friend, you have left us, but you will never be forgotten. So I hope him and his work will never be forgotten. So we'll just observe a minute silence. And those who would like to say Surah Fatiha, please do. Thank you very much. Well, we are talking about PCNL today, and we couldn't be more luckier to have two very nice speakers. We have Mr. Shabi Ahmed, who is a consultant urologist with special interest in percutaneous surgery. He works in Birmingham. And then we have the legend, Mr. Mahesh Desai. And I think it's a great honor for us, Dr. Desai. Your presence will really make this session into a memorable one. So I'm going to little touch upon standard prone PCNL, something that we have all learned as a urologist when we were in the training phase. And then some of us have gone on to do supine and other position PCNLs. My own story of PCNL which started in the early 90s. And I have two landmark figures in my life, in my quest to learn this procedure. And first one was this gentleman, Mr. Hugh Whitfield, with whom I saw the first PCNL way back in 1992 in Central Middlesex Hospital and Institute of Urology in London. And so that was my introduction to PCNL long time back. And then exactly 1 decade later, I visited a beautiful place called Nadiad. And we were very fortunate that our host, Mr. Desai, was really not a host in terms of improving our professional abilities to understand the fine things about PCNL, but he hosted us like kings. So we really had a wonderful time so many decades back in Nadiad. So the question is, PCNL prone, why or why not? And I'm going to quickly look into these, that why should we do PCNL in a prone position? We all have learned PCNL in prone position. We know it provides a broader surface area for percutaneous access. It gives you access. Vast majority of us do PCNL through a posterior lower pole punctures, and probably prone PCNL is the best way to get into the lower pole posterior calyx. If you want to have multiple tracks, again, an upper pole puncture, prone PCNL is a very versatile position. Another thing is that because the posterior surface opens up nicely, you have a significant space for manipulation. So you can move around your scope in various degrees and directions in order to go into the various calyces to achieve complete stone clearance. It provides good vision, collecting system, Obviously, your access is such that the incidence of perirenal organ injury is quite low, although in good hands, probably there is not much of a difference, and that's what the data is. However, if you want to do a bilateral PCNL, something that we do not rarely, but quite frequently at times, because of the high incidence of urolithiasis, and to cut cost of patient, we do complex anatomy PCNLs, and in all this situation, and particularly for large stone burden, probably prone position PCNL is better. However, there are reasons why prone PCNL should not be done, and anesthetic concerns are very valid, particularly for obese patients, for patients who have got comorbidities, those who at high risk of pulmonary compromise or cardiac compromise. They are probably better served in a supine position rather than a prone position. And then there are various innovative ways of accessing the urinary tract from below and above, something which is called ESERS or ECIRS, in which you provide good access from flexible ureteroscope from below and percutaneously from above. And probably it's better done in a supine position or modified supine positions rather than in the prone position. However, the prone position PCNL has not been a static procedure. It has gone through a lot of evolution in the last 45 years. We have modified prone positions. We can actually do access to the lower tract as well as the upper tract simultaneously. The implant sheath sizes, and which Dr. Desai is going to talk about in greater detail, has become finer and finer. The use of nephrostomy, various types of nephrostomies, the no nephrostomy or no tube PCNL is an option. A pneumatic and electrohydraulic lithotripsy is fast being replaced with laser, although we still feel for a very large stone burden, particularly the monohydrates that we see very frequently, probably ultrasound is a better source of energy. And I think we can deliberate on this issue as well. They've been concerned about radiation and whether radiation is more on prone or supine PCNL. Again, not a very settled issue. However, there is some data indicating that supine PCNL probably gives lesser radiation than prone PCNL. About the learning curve, I think it's a matter of who is your tutor. You can learn both procedures quite easily. Probably prone PCNL is a much easier procedure than supine PCNL. Advances in minimally invasive management of various complications of PCNL, including colonic injuries and major vascular injuries, has really transformed this procedure. And now you don't really need to do major abdominal surgeries, even for major organ injuries. So, and these are some of the innovations in position of prone PCNL. You can see the Montreal table along with the helmet, which helps in prone PCNL with a mirror in the base, something I think was invented in Mr. Shabi Ahmed's city, not city, London. It was, I think, Guy's Hospital probably, or St. Bartholomew's, where it was first described. Then you have various split leg prone PCNL, in which you can access both the upper tract and the lower tract, although it's slightly more difficult than supine PCNL to access the upper tract through this route, but still it's quite doable. Another position in which your patient is prone, but you have full access to the lower tract. Now, the fact that we deal with such large stone burden, and Dr. Desai probably will talk about it a little more, is that you can split your table considerably, and by splitting it by 30 to 40 degrees, you get an additional about 3 centimeters space between the coastal margin and the iliac crest, something which is a limiting factor at times when you would like to maneuver and move around your nephroscopes in various directions. The iliac crest becomes one of the limiting factor. So in that situation, prone PCNL probably provides you a much more flexibility. Radiation, as I've said, there are issues. There are no clear data indicating probably supine PCNL has a lower radiation exposure both to the surgeon and to the patient, uh, probably because that ultrasound is predominantly used for getting the puncture, but also overall radiation exposure is less. So I'll stop here, and we have two experts. Mr. Shabi is going to talk about supine PCNL, and Mr. Desai is going to talk about the miniaturization of the nephroscopes and his experience. Thank you very much. Shabi, are you ready to share your slides?
Yes.
We'll take questions in the end. So let me stop sharing mine. Please proceed to share your slides.
Can you see my slides?
Yes, perfect. We do.
All right. Thank you very much, Dr. Ahmad, for asking me to come. My apologies. I've got a groggy voice. I just came back from Turkey at 3 a.m. This morning. So it's a bit of a, my voice is a bit off. But my condolences to you as well to start with, because this session was planned a few weeks earlier, and sadly your mother passed away. So my condolences to you and your family for that. Uh, it's an absolute pleasure to share the platform with Professor Desai, who is just not a famous surgeon. He's like a mentor. He's a like a father figure for most of the urologists, and especially you do deal with stone diseases. So it's an absolute pleasure to be with all of you today. So I will talk about my journey of transition from prone PCNL to supine, and how that evolved, and what was my learning curves, and what was the other messages I would like to share with you today. So to introduce myself, I'm a urology surgeon in Birmingham. To my other attributes is that I'm a visiting professor of urology at my alma mater, which is the Dow University of Health Sciences. Currently, I'm the Bowes Treasurer elect and a trustee, which is the British Urology Society. I also work with the Royal College of Physicians and Surgeons as its regional advisor and a tutor, and I've also been involved with local doctors issues in UK involving the Pakistani doctors, being one of the founder members of the Association of Pakistani Physicians on Northern Europe, and an ex-president of Dow Graduate Association. So I work in Birmingham. So Birmingham is just not one city. It is the second largest city, but it is a amalgamation of the Birmingham city itself and six large towns around Birmingham, which encompass to be called as the Greater Birmingham. Okay, so putting all the Birmingham territory together, the Birmingham city plus the six large towns around Birmingham, including Walsall, Wolverhampton, West Bromwich, Coventry, and some other smaller towns, we have a population of more than 10 million. And as the middle slide shows, this is the obesity index of United Kingdom, and the dark maroon or magenta shade shows that it is the darkest in Birmingham area. So yeah, so Birmingham by far and the West Midlands has got the greatest obesity index in the whole of the country, and naturally with obesity comes the problems with diabetes and in turn fitness issues. Because of that, we've got a very high cardiorespiratory in- problems index as well, with a high rate of COPD and ischemic heart disease and so on. And Birmingham is the biggest s- holder of immigrant population in the whole of United Kingdom and probably the whole of Western Europe. And as you can appreciate, wherever there is a migrant population, there is a issue with stone diseases, because most of the people coming from the Asian subcontinent have got a higher index of kidney stones. So I, like with all the urologists, I learned to do prone PCNLs as a trainee and even in the initial couple of years as a consultant. And this is what used to happen, that you start with your retrograde axis, then you turn the patient around, you break the table, do your punctures, and so on and so forth. But with the demographic changes and the challenges which I alluded to, I used to have a problem with a frowning anesthetist at the top of the table every time, and m- every 35 BMI plus patient I was doing a PCNL, there was always moaning and groaning going on one way or the other. And naturally, whenever you are dealing with big patients and doing prone procedures for 2 3 hours, there was a higher risk of complications. And no surgeon leaves home in the morning to operate to create complications, but these things unfortunately do happen, but that leaves a bitter taste in the mouth. So these were the challenges which I was facing in my initial couple of years of stone practice and doing prone PCNLs. The other problem was the nephrostomy, and even as a trainee, I always used to hate the nephrostomy, because you spend your time and you do a brilliant PCNL, but you leave a nephrostomy, and the next morning, instead of being happy, the patient was always moaning and crying with pain. And the reason was not the operation, the reason was this d- drainage tube called the nephrostomy, which was a absolute nuisance. So that caused patient anxiety, discontent, longer stay in the hospitals, and so on. And of course, are in a state funded system, and the more the patient used to stay in the hospital, the more the charges used to go up. So putting all these things together, and I kept thinking how to get things done. So my break came about 2 years in my job, that the lithoclast that we used to use, the pneumatic lithoclast, broke down. And as happens in the National Health Services, that was a later part of the year, and there was no budget to replace it, and we were stuck. We didn't know what to do. So, with the background that we were facing the challenges of big patients, complications, nephrostomy related issues, and so on, we thought, let's do something else. Let's explore our options. So after making the inquiry, I met this amazing gentleman who since then has been my mentor, my like an elder brother, an extremely amazing human being called as Benji Adejoyo, who is a senior stone surgeon in the Stepping In Hospital in Manchester. And I got in touch with Benji, and I said, Benji, see, this is my problem. I am struggling to do prone PCNLs. I don't like prone PCNLs because of the issues. And can you help me out? And Benji, a few years earlier, had started doing the supine PCNLs, and he is now, and even then at that time, was considered a mentor for supine PCNLs. So the gentleman as he is, he said, Shabi, just come over and just spend a couple of days with me, and that will change your life. And indeed it did. My only saving grace was that a few months earlier, the trust had acquired a high powered laser machine, which you would be our source of stone fragmentation. And of course, the mini PCNL was gaining in popularity across the country. So off I went to Banji in Stepping Hill in Manchester, spent 2 days with him, and he did 2 PCNLs in the morning, 2 in the afternoon. Spent 2 days with him, did 8 procedures, and after that, never ever have I done a prone PCNL. This is just a definition of the logistics of supine PCNLs, and this is not my definition. This is what I took from the internet just to explain to people what exactly supine PCNL does or what are the benefits. So it decreases workload for in the operating room or with for the personnel. There's no need to reposition the patient, and single draping is all that is needed for the whole procedure, and it is much more efficient. There is the advantages would be that the patients are discharged early. There are no nephrostomy, so less pain, less moaning, definitely less blood loss, and I'll share some evidence to that effect later on. And of course, less complication. I personally use a 16 French axis, where Dr. Desai will teach us more about other modalities. And for our my practice, we are using the Doppler ultrasound for puncture. Having said that, a safe puncture can be done using fluoroscopy as well in the supine position. Now, funny enough, when I came to the PAUS meeting in October, I did a similar sort of a talk, and at that time there was about 50,000 hits on Google for supine PCNL. Now, few couple of weeks back, when I was redoing this presentation, there are 250,000, so 5 times the amount of Google hits have gone in 3 months. So that tells you that there is so much of interest in this particular modality. This is the standard layout of a theater for supine PCNLs. So, eh, important thing is the position of the arm, as you can see in the patient. This is a right PCNL. The surgeon is standing on the right with the scrub nurse, and the anesthetist at the top. The the C-arm monitor, as well as the video screen is in front of the surgeon, and the second surgeon or the registrar is at the lower end to assist in the retrograde axis. These are pictures from my own theater. So this is a middle-aged gentleman who had a left PCNL under my care few months ago, and if you can see, the patient is in lithotomy position. The arm, which is the left arm, is going on top of the face of the patient, and that is very important because once you abduct and fully externally rotate the arm, that will give you the access to the flank area necessary for the puncture. And for slim and or middle uh, tire built of patient, you need to have a sandbag under the side where you're operating. For bigger patient, probably that is not even required. You do your retrograde access. This is about a 3 centimeter renal pelvis stone, standard for simple PCNLs. You put your retrograde guide wire in, you put your retrograde catheter in, and what I tend to do is to have my access catheter in the upper pole. And I'm a bit particular about that, purely for the reason that once you are in the kidney, the intrarenal anatomy is can be quite deceptive, and only this retrograde catheter, which is there in the kidney, is the surrogate marker to tell you where exactly you are in the kidney. So, again, I would emphasize that whenever you're placing your retrograde catheter, try and put it in the upper pole so that when you do your puncture and when you have access in the kidney, the retrograde catheter will tell you in which part of the kidney you are in. This is just again positioning of the patient. So the point A is the posterior axillary line, point B is the iliac crest, and C is the costal margin. Now the area of puncture is in the confluence of A and C, so around this area. But of course, you are guided with imaging, so you've got your ultrasound, you've got your fluoroscopy that will guide you to know where you're going in. This is our ultrasound device that we use for our puncture. This is my colleague, my IR friend who is doing this puncture. And in this particular case, we have done a lower pole puncture. And mind you, for supine PCNLs, a mid pole puncture is much easier as compared to a lower pole puncture. And the advantage of the going through the middle pole is that you can turn your instrument north and south, so you can get access to the upper pole where the stones might fly away, as well as the PUJ and even proximal girator, and can chase the stone in that one puncture and completely clear the stone. So that is another advantage of the supine PCL and the mid pole axis. This is the standard kit for mini PCNLs. Now, as you can see, there is one step dilator, which is a metal dilator, which is a 16 French dilator. There are two trocars. The smaller one is the standard one, and the longer one is the extended one. And of course, with most of our patients, we end up using the extended one, the longer one. And this is our mini nephroscope, which is a 12.5 French scope going through the 16 French sheath. And this is all instrument that you really need. There is no need for any balloon dilators and things which, for prawns, you need to have various other modalities and gadgets in your armory. So in this particular case, we punctured the lower pole. I normally use a coaxial dilators from starting from size 8 to size 16. So this is probably a size 16. And then do the final dilatation using the one step metal dilator, which I just showed you in the previous picture. And in the last picture, you can see we are ready to go. The dilator is there, and on top of that, the trocar has been placed in. And then the final step is to remove the dilator and put your nephroscope and start your work. And that's what you see. This is your trocar in there. This is my nephroscope already in there, chasing the stone, which in almost certainly the pelvic stones go a bit up whenever you are starting to chase it. And in this case, you've done the stone is gone. So once you have got a good access, and once your devices are in right place and your stone fragmenting facilities are in order, stone fragmentation for standard stones is pretty much a duck shoot. Of course, it's not a one bill fits all. You do encounter strong larger stones, bigger stones, which can take much longer period of time. I At this moment, my only modality available is a laser to fragment the stone. And personally, I use a 550 micron laser, and I've done so for the last 5 years. No, I haven't used any other laser fiber or any other probe. And pretty much this is very helpful for me because it gives you the strength and the power that is needed for large stone fragmentation. Unfortunately, this video is not working, so my apologies. This otherwise I would have shown you the stone fragmentation. Now with the 120-watt laser machine, the right you've got two pedals involved with it. The right pedal gives you the is used for fragmentation, and the left is for dusting. And of course, you have to use both the modalities. So it's wrong to even consider that one will only use right or the left, or just fragmentation or just dusting. It almost inevitably becomes a, a combined process. Now, this is something which will probably change the paradigm of supine PCNLs. And this is the new version of the lithoclast, which is called as Trilogy. And this is going to go through the supine mini kit with a 1.5 French probe. And personally, in my unit, we've only acquired it in the last 2 weeks, but colleagues who have used it are very happy with it. That really shortens the stone fragmentation process in a very spectacular manner. And hopefully, once we start doing that, even the larger stones will break and go out much more easily. So I'm really looking forward for this new maneuver. And you end your procedure by placing a double J stent, whether retrogradely or antigradely, depending upon your facilities. And that's all it is. And the 1 centimeter incision is closed, and that's the end of it. Now, there is always this argument going on how much of a bigger stone can you do with the supine PCNL? And previously, supine PCNLs were sold for smaller stones. Now, this is a picture of another patient of mine who had a complete staghorn stone measuring more than 5 centimeter. Quite a dense stone, as you can see. And we started again with the lower pole puncture, and we started nibbling the stone. It took us about 2.5 hours, but at the end of it, we completely cleared the whole kidney in in one procedure, one puncture, no nephrostomies, just a stent. Patient went home next day, no bleeding, everyone happy. So the myth that supine PCNLs or mini PCNLs are only for small stones is a thing of the past. And really, we've gone through the learning curve, and we've changed the paradigm of the use of supine PCNLs, and doing much bigger stones more efficiently, effectively, and safely, most importantly. When was doing the prone PCNL once upon a time, the patient used to stay for 5 days with a nephrostomy and everything. Now, more than 90% of my supine mini PCNLs go home the next day. So that has reduced the hospital stay by 80%, as was acknowledged in one of the local publications in the UK. And the largest stone which I've done so far and effectively with single puncture is 6 centimeter. Yes, it did take time because of the fact that using laser for stone fragmentation is a tedious process. However, hopefully, with the new trilogy machine, this will reduce the times even further. And of course, the more efficient you are, the more time you can save. The same theater space can be used for another stone procedure. So again, even the management is happy with it, and everyone wins in this situation. Lastly, there's some slides I would show in terms of the evidence for supine PCNLs. Now, the American guidelines, the European guidelines, and the Endourology Society all strongly advocate that stones more than 2 centimeters should have a PCNLs. The evidence is a bit blurred in terms of they don't actually say whether supine PCNL or mini PCNL, but PCNL is PCNL, and the supine does exactly the same job. And this is shown in this slide in the corner, which is from Sharma et al. A couple of years ago, which shows different sizes of standard PCNLs versus mini PCNLs. And then you can see that the free rates were equivalent. The transfusion rate was much lower in the mini PCNLs. The hemoglobin drop was lower in the mini. The operative time was higher in mini PCNLs, of course, because of the laser, but there was much lesser complication for with the mini PCNL. So mini PCNLs is really the future of percutaneous stone surgery, and naturally there are learning curves, and people do take time to embrace new technology. However, this is something that will uh, change and is really changing the paradigm of stone surgery in the world. On this note, I would wish my good friend, the Standards Prone PCNL, a happy retirement. It has done a great job over the last more than 20 years, 30 years, but it's time for other modalities to take effect and uh, put our good friend, the Prone PCNLs, back into the museum. This is just a snapshot of the last 5 years of 126 procedures I've done. They were all supine procedures. As I said earlier, since I came back after visiting and working with Banji in Manchester, I've never done a prone PCNLs. I've never put a nephrostomy. 95% of my patients were discharged the next day. There was no transfusion, no vascular complications. Few patients had septic issues, but they were effectively managed and all made unremarkable recovery. So on this note, I thank you very much for giving me the opportunity to speak with all the colleagues here, and will pass on the microphone back to Dr. Hamad. And lastly, I would invite you all to the British Urology Society meeting in Birmingham, which I'm hosting in June, and I hope to see you all in Birmingham in June. Thank you very much.
Thank you very much, Shabi. You have comprehensively covered the PCNL procedure in supine position, and I'm sure that there will be quite a few converts from this group alone. And we have a wonderful group today with over 70 people attending this webinar. Now it's my unique pleasure and my honor to invite Mr. Mahesh Desai, with whom I have had the opportunity of being acquainted for over 20 years now, when I first visited his unit in Nadiad, India. So floor is yours, Dr. Desai.
Okay. First of all, I would like to thank Hamad for inviting me, and I enjoyed my trip in Karachi with Dr. Azvi and you and all of us. We had a great time, and um, uh, today I enjoyed both the talk. And let me start by how small can you go in PCNL? And uh, now, stone is global and incidence is rising and size is decreasing. It's a recurrent disease. It can destroy the kidney associated with high morbidity, if not mortality. No age is immune, no sex is immune, no race is immune, no region is immune. And there is a paradigm shift from 1980 till now of developing in the minimal invasive PCNL, ESWL, URS, and then there was a there is an instrumental modification in the power, and then today I think we have the safest modality. I started my PCNL in 1985, and so far I have done more than 34,000 PCNL. So what is optimum? The high stone free rate. 1 minute. Yes. What is optimum is to have a high stone free rate, low cost, low morbidity, and a shorter hospital stay. That is our requirement of the third world, developing world. But most importantly, the stone, to prevent the stone recurrence, you must have the stone free rate. Now, today, looking at our analysis of almost 30,000 people, we have the stone size. Nearly 78% are small stones less than 3 centimeter. While Stegon calculus has also dropped, it is at around 21 centimeter. And if you see the line chart, that the PCNL was the main methodology of treating the stone. ESWL has just gone out, open surgery is gone out, but the RIRS is slowly coming up. In last 1.5 years, we see that both are equal. Actually, ureteroscopy is going, flexible ureteroscopy is going up. Not because, of course, there is improvement in the flexible ureteroscope, but because the stone size is small, yeah, and you can manage by the flexible ureteroscopy, and you can do that. We also studied the factor affecting the blood loss while we're doing the standard PCNL, a prospective study which was presented in 2004 by Rajesh Kukreja and ourselves. And we found that does the size of the tract matter? Answer is yes. Uh, uh, we found as the size increases from 24 to 26 and 28 to 30 and 32, the blood loss increases. And especially in pediatric patients, if the single track is more than 22 or less than 10 to 2, there is a significant drop in the statistically significant drop in the hemoglobin. And we found the complication of PCNL like bleeding, perforation, callicial tear, infundibulal tear, persistent leak, pain, nephron loss, all are attributed to the size of the tract. There is a way to look at the PCNL because of the breeding complication, all this thing. Halal in 1997 used a peel away sheath for a mini perk in children. Jackman in 1998 used a small sheath with standard scope, a small Emplas sheath with standard scope. And Negle in 2000 designed the new mini perk, which Stores company has come out. And that from 30 French to 34 French, it is dropped to 15, 18, and 21 French. Mostly we use 18 or 15, and we have a 12 French telescope. And here the energy we use is a laser or a lithoclast, which can go through the mini-puck telescope. For example, this is a stone in the right kidney and the left kidney. What mostly we use ultrasound, and we do the ultrasound guided puncture to the dilated calyx. And you can see the needle going into the dilated calyx. And once it is there, urine comes out. We inject a contrast and make sure our position is perfect. And then we pass a guide wire. And usually with a single, with a 14 French, we do the track and then metal dilatation. And then we put um, um, uh, the nephroscope sheet. And you can see the stone clarity. And ultra with a laser, you are breaking up the stone. At that time, the stone was broken, and all the pieces was to pick up and take it out. And of course, there was always a chance of stone migration into a different calyx, inaccessible calyx. But that we will not know afterward when we do the X-ray. And here you can see the post-operatively, the puncture is correct. We try to take the picture of the track, and usually you will see there's hardly any bleeding. There is some oozing, but there's no bleeding. So we found that miniature PCNL is reasonable because when we use a shock wave, the relative low stone free rate after the lithotripsy, higher morbidity of conventional PCNL, and larger stones or accumulation of stone resulted in long operating time in combination with flexible ureteroscopy. So miniaturization of a PCNL was quite reasonable. So at that time, we concluded the similar clearance rate as the standard PCNL when we do the mini-perk for the size 1 to 2 centimeter, longer operating time, but ends more frequently in tubeless procedure as Chabet shown, and significantly less bleeding. Similar safety and profile as a standard PCNL and results in shorter hospital stay. We did a prospective randomized study between the mini-perk and standard PCNL, which we published it, and we found that the hemoglobin drop was significantly less in a mini-perk. That was our main aim, and compared to the standard PCNL. The tubeless procedure was much more with the mini-perk than the standard PCNL. And here you can see the complete clearance was achieved in 96% of the cases compared to 100, almost similar. And we also compared mini-perk to the RIRS because RIRS also gaining popularity between the two. And we found that the complete clearance was 100% in mini-perk and 96% in RIRS. And of course, the retreatment rate was 0, while here retreatment was 3%. And here we have done total 1,731 cases of mini PCNL. PCNL. And then we analyzed 1,083 cases. And then we found this is the stone size was average was 14 plus and minus 3. Creatinine was normal, and number of unit and stone size, and then 31% were female, 69 were male, and the pelvic and the multiple stones were more common than the stone in the upper calyx, middle calyx, and lower calyx. We use the ultrasound, mostly the ultrasound guided puncture, but we also use a fluoroscopy or a combination of both of them. And we found mostly the track we use is a single track, but depending upon the configuration and distribution of stone burden, sometimes we use 2 or sometimes we use 3 tracks to do that. And then most of the time, major of time, we had a tubeless procedure. Either we used to keep a catheter or a digistenting, and sometimes if there is a oozing or a chances of a small stone remaining behind, we put a nephrostomy drain. And this is the operating time was 57 minutes, less than 1 hour. Hemoglobin was drop was 1 gram. Hospital stay was 2 to 3 days, and minimum complication. Post-operative fever was 28. That is the only major complication. But otherwise, bleeding, perinephric, pelvic perforation were minimum. We had cleared almost, except six cases, we had cleared the stone in every case. And in those 6 cases, we had to do second stage PCNL for a residual calculi, or 2 patients require a flexible ureteroscopy or a ureteroscopy to clear the stone which has migrated. Now, that was our experience. What was the Negle's experience? He did a 67 cases, all were tubeless and 92% clearance. Lehme found it's very safe and the clearance rate equivalent to the conventional PCNL. And this Chinese paper was remarkable. He did 4.2 centimeter to 6.3 centimeters, Tegon calculus, as one case Dr. Shaibi has shown. Uh, and the track size was 20 French, 18 cleared in one stage, 20 in two stage, 8 in three stages. None of them needed blood transfusion or a bleeding complication. So that was a remarkable. And so this is the PCNL, and slowly we reduced the size. And now after the initial the 18 and 15 French, then even a smaller came, 11.12 and 8.5 and 9.5 PCNL excess. And that was, this is the stone and with a 7 French telescope. Here is a patient with a stone in the pelvis. Usually this is the prone position, and we have done, I have done in every prone, supine, combined procedure we have done. Once you puncture, you put guide wire, and then you do the single track dilatation, and then you put a sheath over it, and then you put this is the mini perk access, and then you see the stone. This stone looks calcium oxalate dihedral stone, and with laser, in no time it breaks up. But at that the same time, assistant pushes the saline through the ureteric catheter, and all these stone fragments they push out of the nephroscope, so or a nephroscope sheath, and then you have a clearance at the end. But what you do is you break the stone till it becomes a dust, and then that is the most important. And then you make sure that you clear, and it comes into a tubeless. This is the dust you have collected, which you can see it. And this is a post-operative picture. Now we find that that time we used to do PCNL, there was stone migration in a very inaccessible calyx or upper calyx or a lower calyx somewhere. For that, to do the standard PCNL was difficult. So what I developed, this is our hospital development, is we use 16 French needle, which comes in a three part, is a 4.85 French sheet, and this is the 3 part. And then again, we can use the 8 French because this is malleable, this is little rigid, and we can use this sheet. And then this is a telescope, which is 0.9 millimeter. You can do it is a totally flexible. And then this is the sheet where attachment where you can pass a telescope. This is the irrigation, and then telescope, bivalve needle, shaft, and irrigation, and then you can puncture. Once you puncture, you change it to three-way connector, where one is the irrigation, one is a laser fiber, and another is a telescope. And you can puncture. Either you can use a laser or you can use a small lithoclast. So all that thing, you can use it. And then the connection is above, so there is no weight on the telescope. For example, this is a small stone at the PUJ of places. Kidneys gets dilated. Patient was getting lots of complaint. Here we have puncture with the needle, and here the stone is seen. You can see the vision is so clear. And here is the telescope which we are putting into it, and then with the 100 micron laser fiber, we can break the stone into a small fragment. Here most of the time the stone size is small, so it doesn't take more time to fragment the stone into a dust, and then it passes. But one of the thing was, very often when you are trying to manipulate, it might bend the needle, and then sometime it can cause injury. So here at the end of the procedure, we take out, and there is hardly any small wound which is done that. And this is the post-operative picture. And we have done 232 uh, cases which we published. And here the complete clearance was 92%, and micro PCNL was done in 77%, and mini micro PCNL was done in 81%. And here we did a multi-centric prospective randomized trial, and we did 70 cases in 7 centers, and we had 100% clearance, and most of the complication 1 and 2 Cleveland grade. And then we found that the 4.5 French needle was good for a stone which is less than 1.5 centimeter, preferably calcium oxalate dihydrate, and we use a laser. Or we use 8 French sheet for the stone between 1 to 2.5 centimeter, calcium oxalate monohydrate, we use ultrasound or lithoclass. So patient selection, either lower callisis, unfavorable anatomy, pediatric patient, ectopic kidney, callicial diabetes.
A Store's mini perk system,
Now,
which comes
this is
in three sizes: 16, 18, and 21 French.
So what we do that after this, we develop a suction with the help of EMS. And this is the cannula, which is a 4.5 French, and that is where you can 365 macron fibers can pass through the cannula. And then here through the suction tube, we can pass the laser. And then I will show you one case where there's a standard PCNL. This is a large stone, and we did ultrasound puncture into the collecting system, which is going straight to the pelvis, and stone was large, so there was no problem. And here we could took it out, and here the laser setting was 0.5 into 1.5 joules or a 6 to 20 hertz. And here we have done a mini perk, and you can see the stone. And then we found that when you dust the stone, we would like to take it out. And here, by using this suction device, um, um, we could break the stone, and at the same time, we could suck it out. So here you can breaking the stone. You are same time you can see the small fiber. You can adjust the laser setting depending upon the density of the stone and the stone fragments. They are all sucked out. And so very important, that a small stone can cause, retained stone can cause the recurrence of the stone. So you need to clear it up. So this is how we clear up. And then we have done a significant number now. Anyway, we done 60 cases, and then stone size was about 2 centimeter, and average track size was 16, and then hardly any drop in a hemoglobin or a complication. Um, and here you can see the fragmentation score, the vision score, the complication minimum, and 96 to 100%. So suction does help. So there is a paradigm shift in the idea, the stone disintegration by energy, either shock pulse trilogy, which has been shown, and Moses laser or thulium. This is a laser, and this is the mechanical energy suction ultrasound with an impactor, where you can break the stone. And suction clearance, I think this was very important development, which is either there is a tube suction or a sheet suction, and or even a flexible ureteroscopy. You can have a CAVAC and you can do the suction. Now, for example, this is a shock pulse by Olympus. This is a trilogy, and this is the Moses laser and thulium. I have all the four, and we did lots of prospective studies to test with the amount of energy which is done. For example, this is the stone, and here it is a large stegon calculus I use for a trilogy. And this is a thulium laser. This is the Moses laser. The stones were a little larger. And then you can see that what is important is a fragmentation into the dust, and the dust can be sucked out. So energy is now, with the energy which is available, it is possible to use a mini perk to use this either trilogy or shock pulse, or you can use a thulium with Moses, or you can see that the stone is fragmented into a dust, and dust can be sucked out. Either use a tube suction or a sheet suction. And with that sheet suction, whole thing can be turned out. We are using the Shah suction, tube which is developed by a urologist, Kaushik Shah. And at the end of procedure, it's all tubeless, and you see the suction which is sucked into the tube, and this is a suction. And then we divide the stone which is fragmented in a size which is less than 1 millimeter, between 1 and 3 millimeter, more than 3 millimeter. So you can see the see like with the triology, you can see the dust is very fine. Again, in a Cleopatra or in a thulium, you can see the dust is very fine. And here the fragmentation is good. So we have divided and tried to find out how we can do it. With suction, you can reduce the time of fragmentation and clearing the stone. And this is we have done significant number of cases on each arm, and we found at the end of procedure, we could do 100% clearance in a stone. And we have done a CT scan after 48 hours. So we could do that. So another thing which Hamad talked about, the radiation exposure, and we did a standard PCNL, and the radiation exposure was a mini sheet for a mini sheet, and a mini. This is the radiation in the standard 26.5. In a mini, this thing it was a 0.29. So in mini perk 21, and this 0.18. And if you see macro perk is 4.5 is a sheet, but 0.11 is a radiation. Right? RIRS is almost similar, 0.19. So radiation hazard has become reduced to the patient as well as to the surgeon. So from a standard PCN, this is the again radiation from reduced from 0.29 MCE and then to 19 in mini perk, and macro perk is 0.11. So if you have a stone, some people are very fond of flexible ureteroscopy, and they do the RIRS up to 3 centimeter of the stone with suction or with testing, and the remaining part they use a standard PCNL. While what we do is we use for the small stone macro perk or a mini perk access, or a little larger stone, we use a mini perk. Even in Stagon calculus, we do the mini perk, but standard PCNL, if there is a configuration of stone or a distribution of stone is such that you may need more puncture, but end result must be total stone clearance with a minimum complication and morbidity. So you are the stone, you are the chisel, and you are the sculpture. You can plan it out. Thank you.
Thank you very much, Dr. Desai. It was, as always, a wonderful talk, sharing from your huge experience, probably unparalleled experience in this arena, and now you have shown quite a significant experience in many PCNL as well. There's a question about hypermobile kidneys, and how do you tackle that situation, sir?
Well, when you have a hypermobile kidney, the first thing I do ultrasound guided puncture. I put saline into the collecting system, and then once you plan and make a small incision, I put a needle straight. I don't go slowly. I go straight. Before anything move, it goes. And I asked the anesthetist to stop the breathing at the time of I puncture the thing. Once the needle is inside, then there is no problem. But then one thing you must remember, the mobile kidney can be up and down with the respiration, but it can also, while puncturing, it can go medial and more medially. So when you are puncturing as ureteric catheter, which you showed the importance of the ureteric catheter was that you don't dilate beyond the ureteric catheter. Make sure you are there. So you will prevent the perforation.
Perfect. Any closing comment, Shabi?
I think with regards to the hypermobile kidney, and as Dr. Desai rightly says, what I forgot to mention in my presentation was that we only use one single metal guide wire. So once your puncture is done and you've put your guide wire in, then the mobility of the kidney is in your control. Then the kidney does not move as it wants to. And of course, the anesthetist help is very important. Even when you are stone fragmenting, slowing the respiration is very essential, because otherwise this kidney can be a bit jumping here and there. So it is a combined effort in terms of your equipment as well as your anesthesia support in dealing with these.
One more thing is, as you rightly said, the guide wire I choose is a little semi-rigid rather than a glide wire. Glide wire can bend while you are
Yeah.
dilating the kidney, but if you use semi-rigid, it will do it. Now I use a screw dilator, so which goes straight way to 14. So there are less step of dilatation than you may be able to do that. I very often I see nowadays if there is a Stegon calculus, I plan out, but then I use a combined procedure in supine. You'd use a PCNL with flexible rotoscopy. And I think that both of this help. Even for a large stone, if I'm doing a flexible uteroscopy, I would put a small PCNL cannula because that with suction. So while I'm doing the flexible rotoscopy with irrigation and high power laser, the dust will suck out and the thing will get clear there and then. Plus, it is has an advantage. This suction has an advantage that it keeps the intrarenal pressure low. There is no intravasation. So post-operatively, kidneys don't swell, so they don't get pain. That's why you can send them home next day because there is hardly any pain because of
Yeah.
suction effect. The kidneys there is no swelling.
Thank you very much. I think we had a wonderful audience today. We have over 70 people attending, and they must have learned a lot from the experience of Mr. Shabi Ahmed and Mr. Mahesh Desai. Always a pleasure to have you, sir. To hope to engage you soon again in another webinar of conceptual basis of urology course. Have a very good evening, and thank you very much again.
Thank you, Ahmad and
Thank you.
Professor Shabi. Thank you very much.
It's an absolute pleasure, sir. Hope to visit your institute at some point.
Please, it will be our pleasure. And one thing I was telling Ahmad is I have seen your papers from Karachi, and in that area, the stone analysis, and if you do the stone analysis at our place, almost similar. So
Yes, that's correct.
we have a similar stone, the calcium oxalate monohydrate mostly, and with a houseful in it. So we can always do the combined study and thing like that, multicentric.
Absolutely. I think there is so much numbers in the subcontinent that you can change the whole paradigm of stone analysis and stone intervention across the world.
Right, right.
Thank you
Thank
very
you.
much, sir. It's an
Thank you,
absolute pleasure.
everybody.
Thank you.
Good night.